Good afternoon, and thank you for joining us for the St. Louis Metropolitan Pandemic Task Force daily briefing with Dr. Alex Garza. The briefing will begin shortly. Dr. Garza will take questions that have been submitted by members of the media after he makes brief remarks. Reporters who have questions during the briefing may also submit those to the task force public information contacts via email, and we will attempt to address those during the briefing or as quickly as possible after it concludes. I'll now turn the briefing over to Dr. Alex Garza. Thank you.
Okay, thank you. Just a really quick technical check. We don't need those to be on, correct? The phone lines.
Correct.
Okay, thank you. All right, good afternoon, everybody, and thanks again for joining me today. As was mentioned, my name is Dr. Alex Garza, and I'm representing the St. Louis Metropolitan Pandemic Task Force that includes Mercy, BJC Healthcare, SSM Health, and St. Luke's. And again, thank you to all of those in the media who are participating with us today and are sharing factual information with the public. We very much do appreciate your efforts with this. Now, we've received some questions in advance of the briefing, and we'll address those shortly. If reporters have other questions, please email those to the Task Force Public Information contacts, and we'll do our best to address those during this live stream or later today. So yesterday, I shared with you some information about modeling across our metropolitan statistical area, and so I thought it would be important then to share with you what that actually means. And so when we're talking about statistics and we're talking about a metropolitan statistic area, this is a map that shows the counties that we're talking about. So as you can see, it's a rather large statistical area. It has around 2.8 million people included in that. And so when we talk about when we're using our models, that is the statistical area that we're talking about. I also wanted to follow up on a couple of other things that we spoke about yesterday, and one was where I had mentioned we expect about 80,000 cases of COVID by the end of April, and again, that includes this 2.8. That's from this 2.8 million people within the MSA. Now, those 80,000 are not 80,000 people that are going to be tested positive for COVID. Those are 80,000 people that have been exposed and become infected with COVID, and a large percentage of them are not going to have any testing at all. In fact, around 30% of them are going to be completely asymptomatic or not have any symptoms at all. So we know from this disease that there's a significant portion that don't have a fever or a cough or anything like that. In addition, there's going to be a significant percentage that have what feels like a cold or like a bad flu that will probably not get tested either. And so when I talk about that 80,000 number, that's really a total population of people that we believe have been infected with the COVID virus based on our modeling. Again, about 30% will remain asymptomatic, but they will continue to spread the virus, and so that's one of the challenges that we have with that asymptomatic population. And so that's why it's, again, very important that we practice all of our social distancing, all of our hand washing, keeping surfaces clean, all of those different things, because it's difficult to tell who is infected and who isn't just based on those symptoms. You also heard me talk a little bit about what our models are showing for total numbers of infected that we expect at the peak. And you heard me talk about anywhere from 1,300 up to more than 3,000. And again, those are contained within that 80,000 population. And so there will be a certain percentage of them, it's usually around 15 to 20%, that are going to require hospitalization. And our model is showing that that number could be anywhere from 1,300 up to 3,000 at the peak. And so that isn't new every day, that's accumulating over time. So at the peak, it would be 1,300 to 3,000 that require hospitalization. So that sort of, again, reinforces the idea that we believe that a surge is coming based on our models. And the only way that we can slow this surge down or make it so that our healthcare systems can handle the surge in patients more appropriately, as well as take care of those other patients, will still show up to the hospital is to decrease the number of people that become infected. And you've heard me say this over and over again, that's really up to the community on how well we respond to that. And that's following all of those social distancing rules, washing hands, keeping surfaces clean, all of those things that we need to do to keep that number manageable, to keep each other well, and to save lives. Now let me move forward with some of our current picture. And so these are as of today, and these data are combined from the major healthcare systems. So as you can see, hospitalizations have increased from 495 to 545 to 586 today. The number of patients in the intensive care units have increased from 224 to 239. And the number of patients now requiring ventilators has increased from 172 to 186. And again, these numbers are fairly consistent with the proportions or the percentages that we've seen of our patients. 70% of those that get admitted to the intensive care unit are ultimately going to need a ventilator. Now, again, I don't want us to focus on numbers moving from day to day. We want to look at trends. And so I know there's always people want to look from day to day, but really we need to start looking at trends and see how our rules or how are the social distancing and hand washing, how are those impacting the trends. And so those are the numbers that we have today. But we believe that the work that's going on in the region with promoting all of those preventive measures are having an impact. And so that's encouraging, but we also know that we're still on that steep part of the curve, and we need to continue doing everything that we can to slow the spread. So as a task force, we're going to continue to monitor the situation and the resources and look for resources to respond to it. And so that's an update on the numbers that we have today, and we'd be happy to respond to any questions that you might have.
Dr. Garza, I'll now read to you some of the questions that we've received from members of the media, either through email to the public information contacts or via our Facebook page. Mm-hmm. And I would remind members of the media, if you do have questions, you can email those during the course of this Q&A period to the Task Force Public Information contacts, and we will read those to Dr. Garza during the live stream. Dr. Garza, the first question. We saw our biggest jump yet overnight in St. Louis County, up 10 cases to 24. Is there a larger explanation as to why such a dramatic jump?
So I want to make sure I understand the data that we're talking about. So are we talking about the number of positives that have been tested, or are we talking about number of hospitalized patients?
That would be, I believe, based on the question, they're talking about the number of tests.
The number of tests, okay. And so, it's challenging to give a definitive answer to that. And so the reason for that is it could be any of a number of things. So it could be we just performed more tests on any particular day, and understanding that a certain percentage of those tests are going to be positive. And so I would say don't focus on those absolute numbers. It's really the rate that we're concerned about. And we know that testing supplies are a challenge. They're not just a challenge here, they're a challenge across the country. And so on any given day, we can be testing more or less people than the day before, and that's going to influence, that total number that comes out at the end of the day. And I hope I interpreted that question correctly.
Thank you. Next question. Is the data that you're sharing about hospitalizations, ICU, ventilator use available online from the task force?
Yes, it's available on the website. So we post the slides every day on the website.
Next question. Do you know if the health systems are running models including patients from rural areas that lack hospitals who will come to the St. Louis area for care? Rural
Right.
Hospital closures mean that the St. Louis region will be carrying the burden for a lot of the state, not just for the region itself.
Right. So the question is absolutely right. There's been a lot of rural hospital closures, especially here recently, and so they won't be available to take care of those types of patients. So let me go back then to the task force or to the statistical area that we look at. And so as you can see, it does encompass some of the more outlying areas. But when we're drawing the boundaries for doing the modeling, this is the area that we're looking at, is the metropolitan statistical area for St. Louis. Now, clearly, they're absolutely right that a lot of the patients from the rural areas will be coming to St. Louis to get care, and so we will capture them in our daily statistics. But the modeling, so there's two separate pieces of data. One is the modeling data, which you see here, and that's the population that includes. The population that I report on every day on the slides is the population that's within the healthcare systems, which can include people from outside of this area.
Do you have any timeline on when the area will receive enough coronavirus tests to adequately address the pandemic in the way that countries like South Korea have done?
Yeah, difficult question to answer. So as I mentioned earlier, it's not just unique to St. Louis. Every community across the country has a shortage of testing kits. So testing is a little bit challenging. So we run tests within our facilities, and then there's also private labs that run tests as well. And neither of them have adequate supplies to do what's called epidemiological surveillance, which I think is what the question is alluding to. So in South Korea, they were able to do significant numbers of testing to do surveillance. And so they were able to then identify who is infected, isolate them, quarantine them, and that way it decreased the spread. We simply do not have enough testing kits to do have a significant impact on that epidemiological surveillance. And so we haven't seen anything or heard of anything that says there's going to be a surge in testing kits coming down the pipeline. We monitor the number of tests that we have every day. Because of the shortage of testing materials, we focus on high priority needs, and those are people where it makes a clinical decision and healthcare and frontline workers if they're symptomatic. And then there's a certain percentage that we can use for community testing and for surveillance. But it's challenging because we're dependent upon the supply chain. And if the supply chain can't fill those orders, then we're very limited on the amount of community testing that we can do.
How many tests do task force members have currently, and how many are you expecting? And from what sources do those tests come, such as the federal government, state governments, or commercial providers?
Yeah, and so on any given day, there's a different number of test kits available, and then the number of testing that we do. So think about it this way: there's really three different ways. So the first way is really for our ambulatory patients. So those are people that have minimal symptoms, fever, coughs, things like that, who have spoken to their primary care physician, gone online, something along those lines, and then have requested, or their physician or care provider has said, yes, let's go ahead and get the test. So those are people that are primarily done through private labs. And so those are places like LabCorp and Quest. And so those are people that don't have to be hospitalized, things like that. The second group are patients that show up at our facilities. So either in our emergency departments, or they get admitted to the hospital in our intensive care units. And those patients are tested by labs that we have within our healthcare systems. And so that's sort of a separate group of patients, and we can usually turn those results around within the same day. And then the third group that was mentioned is the state lab. And so early on, they were the only lab that was available to do the testing, and that's because they're a resource for the Centers for Disease Control. And they have very strict guidelines on who they do testing on, which, it limited the amount of community testing that we could do. And right now they have prioritized the testing that they will do for first responders and I believe some healthcare workers. So those are sort of the three buckets. The amount of testing ebbs and flows every day. As I mentioned, it is the supply chain really hasn't kept up with the amount that we need to do good surveillance testing, and so that's the challenge that we have right now.
Some questions, Dr. Garza, about the modeling. You touched on this earlier, but just to reiterate, that what area does the 80,000 number in the modeling address, and how broad is that area?
Right, and so as you can see the map behind me, that is the counties that are included in the model. So again, it's a fairly well-defined way that statisticians look at data for metropolitan areas, and so this is something that's fairly standard, depending upon which city you're in. So a Chicago will have a Chicago metropolitan area, and this is St. Louis's, and it includes these counties. So when we're talking about modeling for this county, we include this entire population in there, and it's around 2.8 million people. And then when we run the models, the results that we get out of it are generalized across the MSA as well.
Is the 80,000 figure the total number of people who will test positive, or is that a projection, or does it account for lack of testing?
It does account for lack of testing. So again, this is modeling. So this is a prediction of what we believe the number of cases will be, or the number of people that will have been infected with the coronavirus. It doesn't represent number of positives, because remember, that's dependent upon the supplies that we have. And so there's really no way for us to predict that. So the prediction is, given the spread of the virus, how fast are we seeing the curves move up, things like that, what sort of social distancing measures we have in place. All of those other things get put into the model, so that then we can estimate this is the number of people we believe are going to be infected with the virus by this date.
And is that a cumulative number since the onset of the pandemic?
Correct.
And is that 80,000 people who might have the virus at the end of April or by the end of April? Just how does that timeline work?
That's a good question. So I would, it's hard to pin down, because, and the reason for that is because it's an estimate, and so it's never going to be like, okay, on midnight on April 24th, this is the number. It is at the end of April, we believe there's going to be this many people that have been infected with the coronavirus. It's an imprecise number, and so I don't want to put any more precision to it than it really is. This is an estimate.
And then the same for your number on hospitalizations. Is that's a cumulative number as well?
Correct. And so if you watch the curve, certainly patients don't get admitted one day and then discharged the next day, right? They stay for a period of time. And so as you watch the curve, you keep adding and subtracting people that are in the hospital. So it's a dynamic number. And so that is the number that we believe will be the highest number of patients admitted at any one time at the peak of the curve, if that makes sense.
And will you be breaking up those hospitalization numbers by county, or are those numbers the combined data of the 4 medical systems?
Those are the combined data.
A couple questions that have been posted on the task force Facebook page since we began these briefings. From a user, I work in a care facility for the elderly. How do we as individuals do our best to keep this out of our facility?
Yeah, this is a great question. So long-term care facilities have traditionally have very good measures to prevent disease spread, and the reason for that is this is not new to them. They practice and they have plans for prevention of infectious disease in long-term care. But the bottom line is anything that you can do to decrease exposure and spread. And so those are things such as a no visitor policy, making sure if you have a resident that does have the infection to keep them separated from the rest of the residents. The care workers should be screened every time they come into work. They should have their temperature taken and asked about if they have any signs or symptoms. And then all of the other normal things that you need to do, which is frequent hand washing and keeping surfaces clean. So all of those combined is really how you decrease an outbreak in a long-term care facility.
How are hospitals keeping non-medical staff at your hospital safe? Mm-hmm. Do they have sufficient PPE?
Mm-hmm. So the question really isn't what do you do at the hospital? The question is, what is my level of risk while I'm at the hospital? And so let me give you an example. Somebody who works in environmental services, so somebody who does cleaning, if they're doing cleaning on a COVID unit, they have the same risk of exposure as the intensive care physician or the intensive care nurse. And so they are outfitted with the same personal protective equipment as those workers use. And so that's how we base our guidelines on how we use personal protective equipment. It's really based on risk and not necessarily on what your job is. So there's always a concern about personal protective equipment. We, as I've said many times before, we're operating in crisis standards right now. And that means we have to be very careful about how we conserve our personal protective equipment, how it's used, and then we have plans on how we can extend the use and all of these other things. Now, it's not just about the PPE as well. It's also about how do we work smarter. And so if that is instead of having 5 people taking care of 5 different patients, let's bring those patients together in one unit and then have one team take care of 5 patients, and that way we're not burning through as much personal protective equipment. Or maybe we don't need the food services worker to be delivering food trays for these patients. Maybe the nurse can do that or the physician can do that on top of their other duties. The whole goal is to decrease the use of personal protective equipment so that we can then make sure we're protecting our employees through the long haul. As I mentioned, that peak is going to be in 2 to 3 weeks, and so we want to make sure that by week number 2, we're not running out of personal protective equipment.
Dr. Garza, do we have a number of people who have recovered in the region?
We do, and I've asked the team to begin looking at those numbers so that then we can start reporting on those. I think it's important to share good news stories as well as the statistics that we're showing about hospitalizations.
And Dr. Garza, I apologize, I misinterpreted an earlier question that I was reading from email. The earlier question about the jump overnight in St. Louis County was a reference to the number of deaths overnight. Any insight there?
No, not without knowing some more of the details about the deaths. It'd be hard for me to speculate on why that was.
Dr. Garza, is the just going through my list real quick. I think the last question I have for you, while race data for Missouri has not been released as it has been in Illinois, what are doctors and task force leaders seeing on the front lines? Are African Americans being disproportionately infected and or dying from the novel coronavirus?
So that's a great question. There has been a couple of pieces out in the literature, particularly out of Detroit, and there was one other one that came out today, and I apologize, I don't remember what it was, but showing there was a significant proportion of deaths from African Americans from COVID. And so let me just say a few words about that. And this is really, I think, what we need to grasp as a society, and that is that disease, no matter what it is, whether it's high blood pressure, or diabetes, or any of a number of things, it disproportionately affects those that are socioeconomically challenged and different areas. And so part of that includes also race. And so we've known for a long time that race combined with socioeconomic disadvantages does result in poor outcomes. And that isn't meant to say that people are And so this disease is tearing away the curtain from the festering problems that we have in our communities. People that are socioeconomically challenged, that have been victims of prejudice and other things, are going to be more challenged when it comes to health. They have poorer access to health care. They have poorer access to quality food. They have unique challenges with living conditions, all of these things. And so it's really dependent upon us as a society to improve on that if we want to avoid this disproportionate share of disease on those that are less fortunate. So it's an extremely important question that really is beyond COVID, but unfortunately, things like this, viruses such as this, are going to impact those that are challenged.
Thank you, Dr. Garza. That concludes the questions that the public information team has received today via email. Members of the media are invited to contact the Task Force Public Information Team with any additional questions. We will work to respond to those as promptly as we can. And tomorrow we will also begin collecting questions in the morning for tomorrow afternoon's Task Force Public Information briefing. Thank you for joining us for this live stream, and thank you, Dr. Garza.
Thanks.